Hello, my name is Dr. Maria Ryan, and I serve as the Chief Dental Officer at the Colgate Palmolive Company. And it's my pleasure to welcome you here this evening to our webinar entitled Evidence-Based Approach to Rinsing During the COVID-19 Era. And we have three great speakers this evening who will share their knowledge in this area with you during this webinar. The objectives of the webinar are to highlight the importance of oral health and hygiene, including rinsing to reduce bacterial and viral loads in the oral cavity. We will also be communicating in vitro laboratory results and the results of our first clinical study looking at the impact of Colgate oral care products in reducing the viral load of SARS-CoV-2, the virus known to cause COVID-19 within the oral cavity. Finally, we'll be discussing the role of Colgate oral care products in reducing viral load in an era of viral infections in the dental office and beyond as part of a risk reduction and mitigation strategy. There will be three topics covered in tonight's webinar. The first being the effect of pre-procedural rinsing on salivary viral load reduction in the dental office. And this will be covered by Dr. Cristina Villar from the University of Sao Paulo in Brazil. And she is the current president of the Latin American Oral Health Association. And I can recall as a practitioner having my patients do pre-procedural rinsing during cold and flu season, because it was known that this rinsing could reduce aerosolization of viral particles as well as bacteria during cold and flu season. And so she'll be giving a review of pre-procedural rinsing during her presentation. Her talk will be followed by a presentation from Dr. Carlo Deep from our Global Technology Center in Piscataway, New Jersey. And he will be sharing the data on in vitro efficacy of oral care products against SARS-CoV-2 based on a collaborative effort with our colleagues at Rutgers University. And the final presentation will be on the in vivo efficacy of oral rinses in reducing viral load in the saliva of COVID-19 subjects. And this will be presented by Dr. Leticia Bezanelli from Albert Einstein Hospital in Brazil, where she served as the principal investigator on this project with her colleagues there. Following these three presentations, I will be moderating a session where each of the presenters will take a couple of questions, and we'll have some further discussion on these topics before closing out this evening's webinar. I think this webinar has come at a very important time as more and more data emerges regarding the impact of this virus within the oral cavity. We know that the levels of the virus are elevated in saliva of people with COVID-19, and that's why testing can be done through saliva. We recognize that the saliva can be aspirated into the lung, can be swallowed into the GI tract, and that there are receptors which allow for infection of the virus in the lung, in the GI tract, and in the oral cavity. And these receptors in the oral cavity can be found in the salivary glands, in the tonsillar areas, and on the tongue. So infection can occur in all of these areas. We also recognize that transmission of the virus can occur from the oral cavity, and that the virus can through extraoral transmission be transmitted to other individuals in close proximity. And one way of mitigating this is to wear masks. And some masks work better than others. And another way of mitigating this could be to reduce the viral load that can be transmitted from the oral cavity. And so Dr. Kevin Bird, who was at UNC and is now at the American Dental Association's Science and Research Institute as the ADA Volpe Research Scholar, and his colleagues at the National Institute for Dental and Craniofacial Research at the NIH, and colleagues at the Wellcome Sanger Institute, as well as at the J. Craig Venter Institute, recently published on this, stating that the mouth may be a primary route of SARS-CoV-2 infection and transmission. I'm very proud of the work that Colgate has done in a number of different initiatives to support the communities that we serve and to improve public health. I must say that when the virus was first identified, they ramped up production of soaps, whether they were bar soaps or liquid soaps, for hand washing. And as a healthcare provider, I can attest to the fact that hand washing is the first line of defense against disease transmission. And Colgate was very happy to support the World Health Organization's hashtag Safe Hands Global Initiative by providing 25 million bars of soap that were donated to families in greatest need. And those bars of soap had instructions on proper hand washing to ensure that they were being used properly to help to mitigate transmission of the virus. In addition to the soap that was distributed, an additional $20 million of product, including oral care products, were distributed to families in need. When we think of mitigation strategies, we also think beyond hand washing of social distancing and the wearing of masks. And we do know that some masks are better at preventing transmission of the disease, like N95 masks, while others may not be as effective, like cloth masks. And we recognize that if we could reduce the viral load in saliva, it would make these masks more effective in trying to prevent transmission from the oral cavity out beyond the mask. And when masks cannot be worn because of the need for close proximity of a physician or a dentist who may need to examine the face, who may need to conduct procedures within the oral cavity, reducing the viral load could certainly be very helpful for risk reduction and for mitigation. So we look forward to the talks this evening, and I look forward to coming back and participating in the discussions following the talks. So enjoy the webinar, and I will see you later.
So hello, I'm Dr. Villar. I'm a faculty member in the Department of Periodontology at the University of São Paulo in Brazil. The title of this talk is the effect of pre-procedural rinsing on salivary viral load reduction in dental office. Most dental procedures generate aerosol. However, this aerosol is contaminated. It contains microorganisms derived from the patient's oral cavity, including bacteria, fungus, and viruses. Also important, this aerosol can reach distances of up to 26 feet away from its source and remains suspended in the air for long periods of time. Due to this reason, the aerosol has become a matter of growing concern. And along with these lines, in addition to the multiple measures that are currently used in the dental office to prevent cross-contamination, such as hand washing, the use of proper PPEs, and surface disinfection, pre-procedural rinsing has been suggested as an important strategy to reduce bioburden and further reduce the risk of cross-contamination in the dental office. Several studies have investigated the effect of pre-procedural rinsing in reducing the microbial contamination of dental aerosol. However, these studies have mainly focused on reductions of bacterial loads. One of these studies evaluated the effect of pre-procedural rinsing in reducing viable bacteria in the aerosol during a dental prophylaxis with a ultrasonic scaler. In this study, 60 patients were randomly assigned to 4 groups: no rinsing, water, cetylpyridinium chloride, which from now on I will call CPC, plus zinc, and chlorhexidine. So the subjects rinsed for 1 minute with 20 milliliters of their assigned rinse solution. And after that, the patients sat on the dental chair, and 3 agar plates were placed on a support board, as shown here in the picture. 1 agar plate was placed on the volunteer's chest, and finally, another one was placed on the clinician's forehead. After 10 minutes of a dental prophylaxis using an ultrasonic scaler, the agar plates were removed and incubated anaerobically for 72 hours. The total number of bacterial colony-forming units detected in the aerosols of volunteers that rinsed with chlorhexidine, here shown in yellow, or CPC, shown here in blue, was significantly lower than of the subjects who did not rinse or rinsed with water. And same results was also observed when each of the locations, the support board, the clinician, and the volunteer was analyzed separately. So altogether, this data supports the hypothesis that both CPC and chlorhexidine are effective in reducing the bacterial loads in the dental aerosol during a dental prophylaxis using an ultrasonic scaler. And the data from this study have been confirmed by other clinical studies, and more recently by a systematic review that was published in 2019 that demonstrated that the use of a pre-procedural rinsing can reduce the bacterial load in the aerosol by 65%. However, as I mentioned a little bit earlier during this presentation, all this data only refer to reductions in the bacterial load. And now, during the COVID-19 pandemics, we ask ourselves, what is the effect of these mouthwashes in SARS-CoV-2 inactivation. So SARS-CoV-2 is an enveloped single-stranded RNA virus. And to act as a pathogen, SARS-CoV-2 uses its spike protein that is located on the viral envelope in order to gain access to enter inside of the host cells and cause infection. On the other side, the evidence is very clear that the angiotensin converting enzyme 2, known as ACE2, that is expressed on human cell surfaces, acts as a receptor for SARS-CoV-2, allowing the entry of the virus inside of the host cells. It's very interesting that in addition to being expressed on the lungs, the heart, kidney, and intestines, ACE2 is also expressed on the surface of epithelial cells from the oral cavity, especially in the mucosa of the tongue. Moreover, there is some good evidence that the number of ACE2 receptors is significantly higher in the minor salivary glands than in the lungs, which suggests that salivary glands may be a reservoir for SARS-CoV-2. In fact, a recent study, a cross-sectional study, identified the presence of SARS-CoV-2 in the saliva of 91.7% of patients with a laboratory-confirmed diagnosis of COVID-19. And what is also relevant is that SARS-CoV-2 load in the saliva can be remarkably high, especially in the early stages of infection, when infected patients, both symptomatic and asymptomatic, have an average 3 million viral copies of the virus per milliliter of saliva. Finally, it's also interesting to highlight that the SARS-CoV-2 that is isolated from the saliva of infected patients is stable at room temperature for long periods of time, which suggests that the saliva can act as a source of SARS-CoV-2 transmission. And for these reasons, it's very likely that reductions in the salivary load of SARS-CoV-2 might be an important strategy to reduce the risk for COVID transmission in the dental office. Since when a patient cough, sneezes, or even when a patient talks, droplets of saliva are released into the air. These droplets of saliva remain sustained in the air for less than 10 minutes and can only allow transmission of SARS-CoV-2 within a short range, within less than 6 feet. However, the aerosolized SARS-CoV-2 remains suspended in the air for longer periods of time. The viable virus can still be detected after 90 minutes in the air and can travel greater distances as up to 26 feet. And for these reasons, reduction on the salivary levels of SARS-CoV-2, it's an important strategy to prevent cross-contamination in the office, along with other measures that are currently used. And since the beginning of the COVID pandemic, different health authorities in different countries have recommended the need to pre-rinse with chlorhexidine, CPC, hydrogen peroxide, or povidone iodine prior to starting a dental procedure. Initially, these recommendations were based on the effects of these substances in other enveloped viruses, since their effect on SARS-CoV-2 was initially unknown. But since then, the evidence has begun to emerge, and as we expect, the first evidence came from some in vitro studies. And the rupture of the viral envelope, it's a very good strategy to promote the inactivation of enveloped viruses. And this is the mechanism of action of two of the oral rinses that are constantly used in the dental offices, the chlorhexidine and CPC. Only one study evaluated in vitro the effect of chlorhexidine against SARS-CoV-2. And in this study, chlorhexidine at 0.2% was shown to have a weak activity against SARS-CoV-2. In a very similar way, only one study evaluated in vitro the effect of CPC against SARS-CoV-2. And according to this study, CPC has a very strong virucidal action against SARS-CoV-2. In addition to this, SARS-CoV-2 is vulnerable to oxidation. And because of this, since the beginning of the pandemic, several health authorities have recommended the use of mouth rinses with oxidative action, such as hydrogen peroxide and iodopovidine. And the in vitro studies have shown that hydrogen peroxide has a moderate effect against SARS-CoV-2, and povidone iodine has a strong virucidal action against SARS-CoV-2. However, it's important to highlight that the povidone iodine has a very short action inside of the oral cavity, and it's also contraindicated for patients that are allergic to iodine or that have thyroid diseases. In addition to this, povidone iodine is also contraindicated during pregnancy and treatment with drugs that contain lithium or radioactive iodine. And therefore, before using or prescribing povidone iodine, the patient's medical history must be carefully reviewed. So the first clinical evidence of the effect of chlorhexidine against SARS-CoV-2 was published this last May. And this was a clinical report of 2 patients that were diagnosed with COVID-19. And according to this report, a single rinse with 0.12% chlorhexidine was able to reduce the burden of SARS-CoV-2 in the saliva of infected patients. And this effect, as you can see here in the graph, was more pronounced on the 3rd day of hospitalization when the patients had a higher viral load. So here we can see in the blue line and in the red line, a decrease in the burden levels of SARS-CoV-2 in the saliva of these 2 patients on the 3rd day of hospitalization. The effect was not so high on day 6 of hospitalization. And this effect was maintained for 2 hours. After 2 hours, however, the viral loads increased again. And it's very likely that this increase after 2 hours is due to the release of new viral particles from the infected salivary glands. A second clinical report evaluated in 4 COVID-19 patients the effect of 1% povidone iodine. And according to this study, a single rinse with povidone iodine was only able to reduce the burden of SARS-CoV-2 in the saliva of the 2 patients that had a higher viral load in the beginning of the study. So this is the patient in red, and here showing the patient in purple. And that this reduction was able to be maintained for 3 hours. However, it's important to highlight that in the previous study, this study had a very small number of subjects. The first study had only two subjects, and this second study had only four subjects. So there's a very limited number of study subjects. In addition to this, both studies lack a negative control and lack statistical analysis to firmly conclude the efficacy of the rinse. Subsequently, a prospective study with 10 patients diagnosed with COVID-19 revealed that a single rinse with hydrogen peroxide did not reduce the burden of SARS-CoV-2 in the saliva of infected patients. So this first figure here is the baseline data, and then on the right we have the viral copies after the rinse with hydrogen peroxide. However, this study, we were able to observe that the patients that had a higher viral load at the beginning of the study were the patients that presented a tendency to reduce viral loads after rinsing with hydrogen peroxide. Finally, a randomized controlled clinical trial evaluated the effectiveness of 3 mouth rinses in controlling SARS-CoV-2 loads in the saliva of infected patients. So in this study, 16 patients diagnosed with COVID-19 were randomly assigned to 4 groups. Povidone iodine, shown here in blue, chlorhexidine in red, CPC in green, and water, shown here in gray. And the results from this study were shown as were reviewed in CT levels. And the CT level, it's important for us to know that CT levels are inversely related to the number of viral copies, which means the greater the number of viral copies, the lower the CT number. And in comparison to the water, the CT values were significantly higher, which means less virus in the CPC group at 5 minutes and after 6 hours of rinsing, as well as in the povidone iodine group 6 hours after rinsing. And this study did not show any difference between the 3 different mouthwashes, chlorhexidine, povidone iodine, and CPC. However, as we can see here, this was a study that was conducted with only 16 patients that were divided in 4 groups. So therefore, is a study that was performed with a very small sample size, and the data from this study needs to be confirmed by larger randomized prospective clinical trials. So based on all this, we can conclude by saying that the mouthwashes can reduce the salivary burden of SARS-CoV-2, and it's possible that when the pre-procedural rinses are done in conjunction with other measures, such as the use of appropriate PPEs, hand washing, surface disinfection, and social distance, they can contribute to further reduce the risk of SARS-CoV-2 transmission in the dental office. This data presented here is preliminary. The published data is still preliminary and does not support the superiority of one specific mouthwash over the others. Finally, it's also interesting that the in vitro data does not necessarily reflect the clinical results. And to end, it's just important to keep in mind that the pre-procedural rinses should not be regarded as a therapeutical strategy because they do not interfere with the replication of the virus inside of the host cells. The pre-procedural rinses instead shall be seen as a preventive measure to mitigate or lower the risk of cross-contamination in the dental office during any time. So I thank you for your attention and hope you enjoyed this lecture.
Hi, good afternoon, everyone. My name is Carlo Dave from Early Research Oral Care here in Colgate Palmolive. And today what I'll be going through would be some of the in vitro data that we've generated in collaboration with Rutgers University regarding the efficacy of oral care products against the SARS coronavirus 2. In Colgate, we actually have a number of different programs that are involved in helping to control or mitigate microbial accumulation across a broad different number of surfaces, including home care, personal care, and oral care. And in a number of these different products that are associated with these different categories, there are actually a number of different actives that are used in order that have been shown in a number of different studies to effectively control viruses and bacteria. Within the oral care area, there are 4 specific active ingredients that are known to be effective at controlling microbes. That's chlorhexidine, CPC or cetylpyridine chloride, hydrogen peroxide, and 2 different metals, stannous fluoride and zinc. Now, these ingredients are actually found in a number of different products in oral care. Specifically, they can be found in mouthwashes and in toothpastes. A lot of these viruses and bacteria typically are termed to be microbes or microorganisms, and typically they're used interchangeably. But one thing to point out is that there are actually distinct differences between bacteria and viruses. Bacteria are living single-celled organisms. They have their own metabolic function and can respire or breathe oxygen. And there are some cases where they don't require oxygen, but those are very rare. But generally, they do have the ability to self-multiply. And lastly, bacteria are considered to be opportunistic pathogen, meaning they require specialized conditions and environments in order to effectively infect a host like us. But one thing that's good about them is that once infected, a bacteria can be easily treated with antibiotics. Viruses, on the other hand, are non-living entities, and they're actually a lot smaller than bacteria. They don't have their own respiratory function as well as metabolic function. In addition, they can't replicate by themselves, and so they must actually infect a host and hijack the host's metabolic and replication machinery in order to successfully multiply. And because of these, viruses are actually considered to be obligate intracellular pathogens and have been shown and have been observed to infect a number of different cells, including bacteria and humans. One thing to point out is that while viruses do not respond to antibiotics, typically when you go to the doctor with a viral infection, they do prescribe to you an antibiotic, and this is due to helping to control secondary infections from bacteria that are associated with viral infections. And lastly, one thing to point out, because viruses are not alive, viruses can only be neutralized or inactivated, while bacteria can be killed. In today's world, probably the most recognizable virus today is the SARS coronavirus 2, or severe acute respiratory syndrome coronavirus 2. It is actually the causative agent for COVID-19. And to date, there have been approximately 57 million cases globally. And these numbers are actually escalating today. And to date, there's also approximately 1.3 million deaths associated with COVID-19. Now, the virus's primary route of infection for the host occurs along the mucosal surfaces. And there are 3 specific areas where this can occur: below the eyelids, inhalation through the nasal passages, and also along inhalation through the mouth, where the virus can then, from these surfaces, can access the respiratory system. One thing to point out is that in patients with severe symptoms, these symptoms are actually due to uncontrolled systemic inflammations or cytokine storm that occurs within the body as a response to the virus. One thing that's also really interesting is that while SARS coronavirus 2 or SARS-CoV-2 is known to be a respiratory pathogen, there are actually some instances where the virus is quite prevalent within the oral cavity. And there's actually a lot of a number of anecdotal reports that are currently being shared from the scientific community, indicating that the virus is readily found in human saliva. And the saliva is actually really important because this is actually one method that the virus can be dispersed to others through aerosolization of the infected bodily fluid. Once aerosolized, the virus can then disperse and infect other individuals. Also, the other thing that is interesting is that the ACE2 receptor and a protease that are important in virus infection along the respiratory route is also found in a number of epithelial cell or epithelial surfaces within the oral cavity, specifically below the gingiva and also in the salivary gland, suggesting that these are potential sites where the virus could additionally infect the host. In addition, in a lot of patients with COVID-19, and you'll hear a little bit more about this later on in Leticia's talk, but in a lot of these patients, they're actually finding ulcerations along the soft surface, soft tissue surfaces, suggesting that there are actually manifestations or oral manifestations of the disease. Because of the potential role of the mouth as a dispersive agent or a dispersive method for the virus, reducing the overall bioburden of the virus in the mouth could be an important precautionary step to help limit the spread of the virus. Just to clarify exactly what bioburden is, viral load, which I will often interchange with bioburden in this particular talk, is really a population of viable microbes in a given volume of bodily fluid. In this particular case, the viral load that we're interested in would be found in either the sputum or saliva. And in cases where, and the higher the numbers of the virus in these fluids will indicate the severity of the infection. And so helping to reduce the total viral numbers within these sites will help reduce or lower the risk of transmission. One thing to point out is that reducing the numbers of the virus within the oral cavity is not going to be treating the disease. Lastly, reducing the bioload at these sites is actually an important in determining the efficacy of our therapeutic agents and antimicrobial products. As I previously mentioned, saliva is an important vehicle for viruses to disperse into or to others. And this is dispersed through the aerosolization of saliva. This can actually occur through a person speaking, coughing, or sneezing. And generally, when someone aerosolizes saliva, there's a number of different size particles, and generally, most of these particles will spread approximately 6 feet away. And this is actually the precedence behind the social distancing of approximately 6 feet apart. What is important, though, is that as a dentist or a dental profession, they typically work around 18 inches away from a patient's mouth, and this really puts them at a greater risk for infection by aerosolized agents. And so reducing the overall bioburden of these infectious particles in saliva will help reduce their aerosolization and help in prevent the spread of disease or disease-causing pathogens, and more importantly, help protect the dentist as they're working with their patients. Now, the oral care products can assist in a number of different ways. We actually have shown in a number of different studies that reducing the microbial load, specifically bacteria, is extremely important in helping maintain oral health. Similarly, we know that helping to reduce the viral load is important in helping prevent their spread. Um, and reducing these microbial loads actually is really important because as you start to reduce them, this is actually going to have an impact in the overall health of the soft tissues inside the oral cavity. Specifically, this would help reduce inflammation along the epithelial layer. And most importantly, this is actually then going to help maintain the integrity of the tissues inside the mouth. Maintaining this integrity of oral tissues is very important in helping create a barrier that would prevent other microbes from infiltrating the oral cavity and having access to the rest of the body. So using these oral care products is actually going to be really important in helping maintain a holistic personal hygiene. Similar to clean hands, what we're suggesting is that it's possible to extend this idea for oral care. Within oral care, as I previously mentioned, we have a number of different active ingredients that are involved in helping control microbes. Like I said, those are hydrogen peroxide, chlorhexidine, CPC, and stannous and zinc. These ingredients actually work in a number of different against viruses and bacteria in a number of different methods. But more specifically, they aim at targeting the viral envelope and disrupting the lipid membrane. And this would actually help neutralize the virus and prevent their ability to reinfect or to infect cells. And a lot of these products are, as I previously mentioned, are present in both toothpastes and in mouthwashes. And these products are aimed to reduce the microbial load inside the oral cavity so that it would help maintain a pristine surface that would then support a healthy innate immune response inside the oral cavity and protect our body from infections. Together, all of these would help maintain a complete health, starting with the mouth. In Colgate, we actually have a couple different strategies regarding the testing of the efficacy of our products against the virus. For in vitro tests, we're currently using this approach, specifically ASTM E1052, as a way of identifying early on how our products are able to neutralize the virus or inactivate them. This is then followed up by in vivo studies to illustrate clinically the ability of these products to reduce the overall viral load inside the mouth. However, this is actually, just to point out, these in vivo studies are not designed to measure the transmission rates or the infectivity of the virus after treatment. So let me just show you guys some of the current results for our laboratory testing, or from our laboratory testing program. As I previously mentioned, our testing was done in collaboration with Rutgers University and the Public Health Research Institute. We've worked with a group headed by Dr. Aland, who is in charge of the Regional Biosafety Laboratory. These labs is actually unique because there's only 13 of them, in the United States that has been set up by the NIH with the BSL-3 or BSL-3 plus capabilities. We've actually worked very closely with Dr. Pradeep and Ricardo to develop specifically some of the methods that we use to test our product, the efficacy of our products. So this is the way we've actually tested the efficacy of our products against the virus. We took a toothpaste slurry or a mouthwash and exposed a suspension of virus for either 120 seconds or 30 seconds. In the case for peroxide-based products, we exposed the virus to the product for 60 seconds. After exposure, the treatments were actually then neutralized, and the viral particles were separated via chromatography. The isolated viruses, in this particular case, were then used to infect a cell line, which is viral cells that are commercially available. These cells were then challenged with the treated viruses for approximately 5 days. After 5 days, we then look via microscope to look for cytopathic effects in order to calculate the TCID50. We can then take this TCID50 values and calculate log reductions. These are actually the results for these studies. And as you can see, a lot of our products were actually pretty effective at reducing or neutralizing the viruses. As you can see in some of our mouthwash containing CPC, we're able to show greater than 2 log or 3 log reduction in viral particles. Peroxyl showed approximately 0.8 log reduction, which is actually approximately 85% reduction. Paragard, which contains chlorhexidine, we observe about 1.7% log reduction, which translates to 98%. Meridol, which we tested, which contains stannous chloride and amine fluoride, showed approximately 2 log reduction, which is approximately 99% reduction in viral viability. For toothpastes, we tested 4 different products: Colgate Total, which contains stannous chloride, that's available here in the US. We also tested a global Colgate Total, which contains dual zinc, a Meridol toothpaste containing stannous chloride and amine fluoride, and a Parodont Expert, which contains stannous chloride and AMF. And in all of these testings, we're able to show at least a 2 log reduction. And in the top 3 toothpastes, we saw a greater than 3 log reduction, which translates to 99.9% inactivation of the virus. So in these testings, we're able to illustrate that our products are effective at neutralizing the virus using in vitro methods. And this is actually going to be important in helping to reduce the overall bioburden of these these viruses inside the oral cavity. In addition, we've actually shown that our oral care products are effective, like I said, at neutralizing these viruses, and this would then translate to helping reduce the spread of the virus that causes COVID. And as you can see, if we can remember, a lot of our numbers are, some of them are not optimal and they're actually falling below 2 log. But in this particular case in time, every little bit counts, and or everything. We actually have a number of different programs that are ongoing to further test our products against the virus and understand how it's able to contribute in reducing the spread of the virus. We have actually a number of different partnerships from around the country and also outside the US. And with that, I'll let Leticia take over.
Hello, everyone. I'm Leticia. I'm a dentist at Albert Einstein Hospital. First, I thank Colgate team for the invitation and the opportunity to be together discussing such an important topic. This is our hospital. Albert Einstein is a Brazilian hospital located in the city of São Paulo. It's one of the most well-known health units in Latin America, due to its quality of care, medical equipment, and expertise at your disposal to address the main types of pathology. The hospital also hosts a nursing school and also a medical school. The education research activities are innovation drives that are not restricted to the patient of the hospital and include a technical, undergraduate, and graduate courses, sophisticated training, clinical and experimental research. The hospital has an oral medicine service, and the dentist works in oncology, ICU, and now in patients with COVID-19. The role of dentists in the hospital offer a complete treatment for the patient, improve the life quality, reduce the risk of infection, reduce hospital treatment costs by preventing oral diseases, and so we collaborated for the best prognosis with the patients, for the best patient prognosis. And for that, oral care is essential. A good control of oral microbiota is very, very important. And how are the oral care protocols in the hospital at this time of pandemic? Unfortunately, until November, there were more than 6 million infected in Brazil, and COVID-19 cases have increased again, requiring more measures implemented to reduce viral spread. We know that many patients with COVID-19 are asymptomatic, but some patients develop mild symptoms and need some kind of hospitalization, while others have more symptoms requiring ICU and intubation. In the hospital, we treat patients with mild, we can see here, with mild, strong, and very strong patients. In the first group of mild symptoms, we observe more frequently chasing taste and xerostomia. In the patients with strong and very strong symptoms, oral alteration is more frequently, and we observe a non-specific stomatitis in 23% of patients, dry mouth, 20%, traumatic lesion, 12%, odontogenic infection, 10%, herpes stomatitis, 9%, petechia, 7%, bleeding, 5%, and oral alteration with less frequently. Today, our protocols in the ICU are like this. First, in patients without suspected COVID-19, we followed hygiene with 0.12% chlorhexidine. And patients suspect or confirmed for COVID-19, first, patient without invasive mechanical ventilation, we use mouthwash with 1% peroxide. And patients with invasive mechanical ventilation, first oral hygiene and peroxide tube, followed by standard hygiene with 0.12% chlorhexidine. Regarding the pre-procedural mouthwash, we establish our protocol as follows. In patients with all suspected COVID-19, we use chlorhexidine 0.12%. In patients suspect or confirmed for COVID-19, we use rinse pre-procedural with peroxide, 1% peroxide. At the dental office, we treat patients with no suspicion COVID-19, but we know that we have it as a symptomatic patient. For this case, are using a peroxide or chlorhexidine. This is our routine inside the hospital, in bed, or in dental office. So it's very important that we do zero studies. This is our in vivo study, which evaluates the efficacy of oral rinses in reducing viral load in saliva COVID-19 subjects. The main researchers are Fernanda, me, Luciana Correia, and Deborah. The objective of the clinical study was evaluate the efficacy of commercially available oral rinses in reducing SARS-CoV-2 viral load in the oral cavity of COVID-19 patients. We use rinses below: peroxide, CPC plus zinc, chlorhexidine, peroxide plus chlorhexidine, and water. We following the manufacturer's recommendations regarding dosage and rinsing time. The study included 50 patients in 5 groups with 10 patients each. The first group used water Other group, peroxide, 1.5%. Other group, CPC plus zinc. Other chlorhexidine, 0.12%. And the last, peroxide plus chlorhexidine. To collect the saliva, patients were instructed to spontaneously expectorate saliva in a sterile tube before starting the mouth rinse. T0, baseline, T1, immediately after, T2, 30 minutes after, and T3, 1 hour after. Then, the key RT-PCR analysis of saliva sample was performed by time point. Okay, and we use the double delta CT formula for this, and we use a double CT formula. For this, we normalized the CT values for each experimental time, T1, T2, and T3, with the CT values for baseline, T0. Controls were considered the CT values for baseline and the other experimental of placebo group. And this showed, and this table showed the quantified viral reduction by key RT-PCR in the oral cavity of COVID-19 patients post-rinsing. Immediately after the rinsing, CPC showed a high-fold reduction. We can see here 20.4 times, followed by peroxide, 15.8 times. Chlorhexidine alone showed 2 times, and chlorhexidine plus peroxide plus chlorhexidine 2.1 times. But the reduction effect in the other experimental times was also significant. You can see here. So we conclude that all the rinsing solution had a positive effect on the viral load, reducing the saliva. The oral rinse test is the study were effective in reducing viral load in the oral cavity after on-time rinsing. The observed effect after on-time rinsing lasted up to 1 hour. The combination of peroxide followed by chlorhexidine showed less effect when compared to other solution tests. And the mouthwash should be recommended as part of health risk mitigation strategy. It's very difficult to carry out in vivo study like this. We need a big team and a specialized equipment. Thank you for the hospital. It's ICU, lab, diagnostic center, hospitalization of critical patients. We have a big team working together. So thank you, and thank you for your attention.
Well, what a great set of presentations that was. I really enjoyed listening to the 3 speakers and the wonderful work that's been done really over the past few months, which is amazing to get this work done in the midst of this pandemic. So we actually had some questions that were sent to us that we're going to go through with the speakers. And I'm going to start with a question for Dr. Villar. And the question is, what is your recommendation for practicing dentists? Which mouth rinses should they use, when, and how often?
Okay, so thanks for the question. According to the preliminary data that has come through the randomized clinical trial that is conducted right now at the Albert Einstein Hospital in São Paulo, Brazil, both chlorhexidine, the CPC plus zinc, and the hydrogen peroxide, they reduce by more than 2-fold the loads of SARS-CoV-2 in the saliva of infected patients. So all these rinses can be used as pre-procedural rinses. In terms of the frequency, we do have some clinical evidence in the literature that the effect of these 3 mouth rinses can last for up to 1 or 2 hours for sure. We don't know furthermore because the studies have not evaluated longer periods of time. But we know that for 1-2 hours, these rinses will cover the patient. So they are well indicated, and a single rinse should be enough for procedures that are expected to be completed within this time frame. Then additional rinses, however, may be required when longer dental appointments are planned for the patient.
Yeah, that's great, and it really is reflective of what was seen in the clinical studies that were conducted. So that's
Absolutely.
fabulous. So the next question is for Dr. Bezzanelli, and that question is, are there plans to publish the data from your clinical research in a peer-reviewed scientific journal, and if so, when?
Oh, thanks. Yes, yes, yes. We are planning to publish the study results. We understand the subject of mouthwash is very controversial, and we need scientific evidence to help make a recommendation for healthy professional. We are hoping to have the acceptance of the article for publication by the end of the month, this month. I hope so. We work hard. Yes, I hope so. This month.
I hope so too. I hope so too. And I know that many of the journals are actually fast tracking a lot of the COVID research because it is so important to the public. So I hope it will come out when you're suggesting perhaps by the end of the month. That would be great. Okay, so the next question is for Dr. Dave. And the question is, what additional clinical testing will be conducted?
So yeah, aside from the Einstein, we actually have a number of studies that are ongoing across different universities, both here in the US and also outside the US. And in those studies, we're looking at the effects of our products in trying to reduce the overall viral load of the virus associated with COVID-19. And we're trying to figure out how do we, and in these studies, we're actually going to allow us to understand also how this reduction in viral load is going to be important in helping us slow down the spread of the virus among infected individuals. We're actually looking at also, in addition to viruses, we're looking at other microbes that are involved because there are other things in the mouth other than viruses. And we're looking at the overall effects of these products in reducing the microbial load in the mouth. And together, this is actually going to help us understand how reducing and limiting the amount of microbes in the mouth can help us maintain a healthy mouth and potentially support health.
Yeah, and I really do think the clinical program is very important, and we have a very robust clinical program to look into these areas because you know, the famous saying is in vivo veritas. And so the in vitro studies are very important, but obviously the clinical studies are the most important as we apply the learnings that we have from our in vitro studies. Thank you. I actually have another question for you. And that question is the virus neutralizing effect solely based on the active ingredient, or could even the foaming agent or detergent provide some effect?
So that's actually a really good question, Maria. And the quick answer to that is currently we've tested the whole formulations in our products, which contains both surfactants and the active ingredients. One thing to point out is that our formulations were specifically designed so that we maintain the bioavailability of our active ingredients, so like CPC or chlorhexidine. And this is actually really important because the bioavailability of these actives has been implicated in the activity of the products in helping fight microbes like bacteria. And there are instances out there that in literature that are also suggesting the potential activity of some of our active ingredients against viruses.
Thank you. Thank you. Yeah, I think the actives are very, very important in the equation. And that's why we see differences when we test different products, right? So
Absolutely.
very important. Okay, so then the next question is for Dr. Villar. How should we use the in vitro results? Is it a useful indicator for the clinicals?
So the in vitro data is very important. It's the beginning of everything sometimes, especially in a pandemics like this one. But the in vitro data only suggests whether a rinse has or hasn't the virucidal action against SARS-CoV-2. So all this in vitro data must be confirmed by clinical trials. And when we think about like the virus, like the in vitro, an in vitro suspension of the virus in a test tube, that certainly doesn't represent the true nature of the oral cavity. So differences can be found between the clinical and the in vitro data. Just to give you an example, for instance, there are some rinses that have substantivity. These rinses can be retained in the oral cavity for prolonged periods of time, up to 8-12 hours. And if you use a single rinse with substantivity, you can have a prolonged antiviral effect in the oral cavity as compared to the in vitro effect of the same rinse. And this, for instance, can even explain why, for example, chlorhexidine had a better clinical effect as compared to its in vitro antiviral outcome. So there are differences, and these are good starting points, but we must be very careful when interpreting in vitro data that cannot be completely true sometimes in the clinical scenario.
That's a very good point, Dr. Villard, because we in dentistry are well aware that chlorhexidine is very substantive, and the studies actually bear that out. That it showed that its substantivity, and it's a very good point about the differences that we see in the in
because
vitro.
the in vitro data wasn't so strong, but then the clinical trial revealed something bigger, and this is a good example that we should be cautious when looking into in vitro data only.
Yes, that's a very good point. Okay, so the next question is for Dr. Bezzanelli, and it is based on your study results, what is your recommendation for healthcare professionals?
Oh, yes, good and important question. Based on our preliminary results, if we think of hospitalized patient who will be submitted to some type of oral manipulation or oral procedure, either by the physiotherapist for an aspiration, or by the nurse, or even by the dentist, it would be appropriate to perform the mouthwash before the procedure. I believe it's important to use it before oral. I believe it's important to use mouthwash before oral procedure. Yes, I believe it's very important based on our results.
Yeah, I could see that, and really, your study is really astonishing because it is in a hospital setting. So these are the sickest patients, probably with very high viral loads. And the impact that you saw with the use of the rinses was very significant, and certainly would help to protect those care workers, as you just mentioned, if they have very close exposure during procedures, etc.
We need to manipulate this patient.
Yes.
It's very, yes.
Very difficult work and very heroic work, really. Okay, so let's see. The next question is for Dr. Dape. Can you provide the methodology used for the in vitro tests?
Sure. So the testing protocol we used It's actually a standardized protocol. It's ASTM E1052. So this is a protocol that's used across a number of different products, both from personal care and home care. This is actually the first time I've used it from an oral care perspective. But this particular assay is actually used to test the efficacy of products against suspension of viruses. And in this specific case, we've tested against the SARS coronavirus 2. But aside from that, we actually work very closely with Rutgers because there are some challenges with the testing. Specifically, like I said, this is the first time the methodology has been used for oral care. So there were some challenges in terms of toothpaste and toothpaste slurries. So what we did was working closely with the university, we're able to refine the methodology to address this. And some of these changes that we did are actually currently proprietary. But once we publish, we're actually planning to publish the manuscript with the full details of the in vitro results and some of the details regarding how the experiments were done and some of the methodologies we used will be included.
Yeah, I know there's a great group there at Rutgers, and they have the BSL-3 facilities and to do this type of work, and it's not easy work.
Oh, absolutely, and they're extremely talented researchers, and I'm very excited that they were able to actually get the results as quickly as they did for us.
Yeah, and very helpful in directing us towards, what we will be using various clinicals too. So it is important, the in vitro work. Okay, the next question is for Dr. Bezzanelli. Can you comment on the results taking into consideration not only the viral load reduction in the oral cavity, but also how long the reduction was observed?
Okay, thanks. Thanks for the question. In our methodology, 4 experimental times were evaluated. The baseline, immediately after rinsing, 30 minutes, and 60 minutes after rinsing. Based on our results, we observed that the study times we were able to evaluate the efficacy of the mouthwash when comparing viral loads with baseline. All rinses still show the reduction, which help us to reinforce the recommendation of the mouthwash before oral procedure. We observe reduction in all times, at least 1 hour.
Yeah, that, which is important if you think about, those procedures you talked about doing, or whether we're doing a procedure in an office, to have those reductions over an extended period of time. But then again, as Dr. Villar mentioned, if you're doing longer procedures, it would make sense to many people to perhaps rinse again.
Mm-hmm.
Okay, so the next question is for Dr. Villar. What are the current recommendations regarding mouth rinses while we are still living with the virus?
So when we talk about these recommendations, we have to remember a little bit that very early on in the beginning of the COVID-19 pandemics, there were many different health authorities from different countries in the world that had recommended the use of a pre-rinse prior to starting dental procedures. And depending on the country, depending on the health authority, they recommended chlorhexidine, hydrogen peroxide, povidone iodine. Initially, these recommendations, as I mentioned a few minutes ago in my lecture, they were based on the effects of these agents against other enveloped viruses, because everything was so new. They didn't know their effects on SARS-CoV-2 initially. But from then to now, the evidence has started to emerge. And what we see right now is that the results from large clinical trials, such as the one that has been conducted here in Brazil, will be very important and are likely to shed an important light for us to really identify optimal pre-procedural rinses. So we know right now, as I mentioned in the first question that I got, that chlorhexidine, hydrogen peroxide, CPC plus zinc, they have an important clinical reduction in this viral load in the saliva. And I think that as more research comes and as this study becomes published, this will help clinicians and health authorities to define new protocols, because the science is evolving and the clinical practice and the recommendations to mitigate and reduce the risk of cross-contamination should follow the same way.
Yeah, that's a very, very interesting point, in that even when the virus first emerged and we were looking to do in vitro studies, we did look at other envelope viruses, and they in vitro, it is different. Looking at the results from the COVID-19 virus versus other envelope viruses. And the same will be true in our clinicals. And that's why it is important that we do clinicals in patients with this virus. Not that it's not important also to do clinicals with the others, because certainly in certain parts of the world, various viral infections need to be addressed, but it's important to actually work with the virus that you are trying to have an impact on. And so right now it's COVID for the world. Thank you. Thank you. That's a great point. Not all envelope viruses are the same, right? I guess that's the point. Yeah.
Yeah, we know that herpes and SARS-CoV-2 are not the same, and among other viruses that are enveloped as well.
Yes. So my final question is for Dr. Bezzanelli. What was it like conducting this study, and having done clinical research for many years, and wearing PPE as a dentist and a clinical researcher? This certainly was different, and I saw the photos in your presentation. What was it like doing a study like this?
Yes. A clinical study is already a challenge. Doing it a pandemic is more difficult. We changed the way that we work to meet current PPE guidelines. So many people were involved, and the family, patients. It's very, very complicated. But we hope the results of the study can collaborate to science and help fight the pandemic. We are all in this together. I hope this study collaborated.
Yes, absolutely. And I have to give credit to all of the researchers, whether it's in the laboratory, working in BSL-3 facilities, or in the clinics, who are on the front line, like our two doctors here today, Dr. Bezzanelli and Dr. Villar. It's so important, the work that's ongoing to really investigate how we can best manage this virus, how we can help people with mitigation strategies so they never get this terrible virus. And all of the work that's ongoing really is amazing. So I'd like to thank all of you for your hard work, and I look forward to the continued work that we will all be doing as we continue to battle this pandemic. But vaccines are on the way, and so there'll be more stories to come as we continue to move through this over the next year or more. But a lot has been done already, and a lot will continue to be done. So thank you so much.
Thank you.
We're now coming to the end of our webinar this evening. It was really a great group of speakers. I learned a lot. I hope that all the people listening to this webinar have also learned a great deal. And I had some takeaways from all of the talks this evening with regard to oral care products and SARS-CoV-2 levels in the oral cavity, and the results from the in vitro studies presented by Dr. Dape suggest that some toothpastes and mouthwashes may help to reduce the transmission of SARS-CoV-2 by temporarily reducing the amount of virus in the mouth. But as I always say, in vivo veritas, and very important, the clinical study presented by Dr. Bezanelli supports this hypothesis, and indicated that some oral care products may help protect frontline health professionals from the spread of SARS-CoV-2, as discussed in the question and answer session with Dr. Bezanelli. Also, the results support currently used safety precautions taken by many healthcare professionals who have patients rinse before a procedure or exam that requires the patients to remove their masks, as described in Dr. Villar's lecture. While brushing and rinsing are not a treatment or a way to fully protect an individual from infection, they may help to reduce transmission and slow the spread of the virus, supplementing the benefits that we get from other mitigation strategies such as wearing masks, social distancing, and frequent hand washing. Colgate is collaborating with numerous investigators throughout the globe to conduct clinical research across the spectrum of COVID-19 to explore the potential of oral care products to reduce oral viral loads as a risk reduction strategy. We think oral care has a role to play in fighting the global pandemic alongside other preventive measures. So we leave tonight's webinar with some new risk mitigation strategies to consider during the COVID-19 pandemic. Rinsing with a mouthwash, in addition to the use of masks, hand washing, social distancing, and hard surface cleaning, can be part of the preventive strategies used to mitigate the virus transmission. Incorporating rinsing prior to visits to the dental practice or other healthcare setting where patients and providers are in close proximity, and an examination may require the patient to remove their mask, can be considered. Pre-procedural rinsing prior to starting a dental or medical procedure, and periodic rinsing could help to reduce the aerosolization and dispersal of the virus during the office procedures being conducted, or when a patient is admitted into the hospital in a hospital setting. We will continue to work on these types of preventive strategies and public health efforts, because we do believe that everyone deserves a future they can smile about, and that together we'll all get through this pandemic. Thank you for your attention this evening, and have a great night.